Central Standard Time over here, and good afternoon, I guess, according to Kenya time. We are going to today emphasize on going over EKGs and apply the knowledge which we have gathered over the past couple of sessions, okay? At any time, if you guys don't understand anything, please feel free to interrupt me. And I will be asking you guys some general questions and asking for your input on these EKGs, and I would appreciate if you guys can participate, okay? All right, so...
Sorry, Asif, I'm so sorry to interrupt, but this session is also being recorded and will be uploaded to Dropbox as well.
Great, okay.
Okay, wonderful.
All right, so if everyone's okay with it, we're going to start, okay? All right. This is the first ECG that I've gotten for you guys, and just look at this ECG closely and tell me if you guys think that this person is having a myocardial infarction, and if so, where do you think he's having it? Which leads do you think show ST elevation over here?
Okay. We may just need a moment for folks to respond.
Okay.
Okay.
All right. Well, the leads which show ST elevations are basically leads B1, where you can see the ST segment to be elevated as compared to the baseline over here, and also lead B2, where there's ST elevation. So this person is actually having an acute myocardial infarction, okay? Especially in the setting of chest pain, we have to take it very seriously. Now, of interest though, you can also see some ST elevations in lead 2 over here, which is raised as compared to the baseline over here, and a little bit of ST elevation is also seen in lead AVF. Okay, just a little bit. All right. Now, this is a little bit of a tricky EKG, so I'm just going to go over it myself. Now, there are two types of myocardial infarctions that can sometimes be very subtle. Okay. One of them is an inferior myocardial infarction, and as we all know from our previous ECG lectures, that the inferior leads are leads 2, 3, and AVF. Okay. And the other one is a pure lateral myocardial infarction, which is lead 1 and AVF. Those two types of MIs can sometimes be notoriously subtle. In this ECG, it's difficult to appreciate, but there is a little bit of an ST elevation in lead 3 as compared to the baseline, which you can see over here, as well as in lead AVF, just a little bit, okay, and just a little bit in lead 2. So always remember to look for ST elevations in the presence of chest pain and typical symptoms. Even mild ST elevations should be taken very seriously. So this patient is most likely having an MI in the inferior region of the heart, based on these ST elevations in leads AVF, lead 3, and lead 2. Alright. Now, how about now? Where do you guys think you can see ST elevations in this EKG? Now this should be pretty obvious for you guys. Okay, I'll just go over it. So
let's just give everyone just one more moment, because I think there's some issues with some mics.
Okay.
So I'm so sorry. Let's give them just a couple of more.
Sure, sure. I'll probably just wait. I'll just probably just wait a couple more minutes, and then I'll restart.
Hello.
All right. Great, Lina. Go ahead.
Hello. Yeah, I can now. I can communicate. Dr. Siwani, kindly repeat the question.
Yes, yes. So I'm saying that this EKG over here is about a patient who comes in to the ER with chest pain, right? Now, whenever you see such an EKG, what do you think is going on here?
On this ECG.
Good, good. So it looks like Fatima just sent me something. I think her mic is probably not working.
Okay.
But she said that you can see ST elevations in lead V2, which is a very, you can see these sharp elevations, right? As compared to the baseline, these STs are very much elevated in V2, in V3, also in V4, and also in V5 as compared to the baseline. So this guy is having a big anterolateral MI. You know, all the leads in the precordium almost have ST elevations from lead V2 to all the way down to lead V5. And the interesting thing in this guy also is that you also see ST elevations in lead 1 and AVL. So this is a huge area of the heart that is being involved. And I'm sorry I probably interrupted you. What were you saying? I'm sorry. Did someone have a comment on this? No? Okay. So it's pretty obvious that this patient is having a huge anterolateral myocardial infarction based on the ST elevations that we see diffusely from lead V2 to V5 and also in lead 1 and AVR. So this patient's MI involves both the anterior wall, V2 to V4, and the lateral wall, which includes lead 1 and AVR. Okay. And you can see these ST elevations marked by the circles on the EKG. All right. So this is an interesting strip, and this probably is a question from your ACLS. So what do you think is going on in this rhythm strip? Okay.
I can see some ST depressions.
So, you know, yeah, so when a patient has a rhythm, so this is a rhythm strip which shows that this is not a normal sinus rhythm, right? So Fatma said this is atrial flutter, and she's correct. So you can pretty much see this sawtooth pattern that you can see over here. See how this is like a sawtooth, up and down, up and down, up and down. This is a typical ECG or rhythm strip of a patient having atrial flutter. Okay, when somebody has atrial flutter, you will see this typical ECG in which you will see a sawtooth pattern. These waves, which go up and down, are called flutter waves, and they represent the atrial depolarization. See how fast they are? The rate is about 300 beats a minute. So the atrial rate is about 300 beats a minute. And the ventricular rate is not that fast, 1, 2, 3, 4. So it's about between 100 and 60 beats a minute. But this is an ECG of a patient having atrial flutter. Now, this ST depression that you see over here that you were correctly pointing out is because of the flutter wave. Okay, this is not a true ST depression. But just because there is a flutter wave embedded in this portion of the QRS, that's why you see ST depressions. But you guys were correct in saying that this is atrial flutter, and the ventricular response rate, as looking at the QRSs, is pretty much controlled. So this is not somebody whose heart rate is going too fast. The atrial rate is really fast, but the ventricular rate, which forms the pulse, is not that fast. Okay? We went over this. And the other thing about atrial flutter is that this rhythm is very regular. You know, when somebody has atrial fibrillation, the rhythm can appear to be irregular, and just by checking the pulse, it will be difficult for us to say whether somebody is in sinus rhythm or somebody is in atrial flutter because it's so regular, you see. Okay? All right. Okay, now, what do you guys think is going on over here? See how there's a PQRS, 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 PQRS. This is the PAC, and then what happens? This patient goes into a very fast rhythm over here, right? So what do you guys think is going on over here? This is sinus rhythm over here, and this is not sinus rhythm. So what is this rhythm called?
this patient is probably getting preventricular contractions.
So this, what you see over here is basically a very regular fast supraventricular tachycardia. It's called an SVT. And the reason we say it is an SVT and not VT is because the QRS morphology is the same as it was in sinus rhythm. See how it's a narrow QRS and there's sinus rhythm over here? The QRS morphology is the same. It's the same QRS, but you don't see any P waves now. Okay? So this is called an SVT, or supraventricular tachycardia. When somebody comes in with an ECG like this, it is very important to see what his hemodynamic status is. If patients are hemodynamically stable, the first thing to do is a carotid massage. And sometimes a carotid massage is going to break this arrhythmia. Okay? So this is a rhythm strip of a patient having SVT, or supraventricular tachycardia, in which we don't see P waves very clearly, but we see QRSs which are regular, and the rate is almost 150 beats a minute. Okay? See how the initial rate in sinus was about 70 beats a minute, and then it jumped up to 150 beats a minute. Okay? So the hallmark about SVTs is that they start abruptly. Okay? And that's exactly what happened over here. Within 2 beats, it went from 75 to 150. It's very regular. As you can see, the QRSs are very regular. They're not irregular. Okay? And we can see no P waves, as we had just discussed. See? Over here, we don't see any clear P wave. This is a T wave. This is not a P wave. Okay? This is a T wave. Right? Okay. So now we're going to go to the next ECG. Okay. Now we're going to discuss a little bit about ventricular arrhythmias. Now when you talk about ventricular arrhythmias, it means that the tachycardia or the arrhythmia is coming from the lower chambers of the heart, which could be the right ventricle or it could be the left ventricle. Ventricular arrhythmias are the most unstable and dangerous ones in patients, especially in patients undergoing cardiac rehab. And they're very common actually in the first couple of weeks. If a patient will have a ventricular arrhythmia, it will usually be in the first few weeks after a myocardial infarction. So when you guys are in a cardiac rehab and you guys see patients having a wide QRS arrhythmia, you guys should immediately seek help. Okay? Now ventricular arrhythmias are broken down into ventricular tachycardia, and this is very regular, and ventricular fibrillation, which is very similar to atrial fibrillation. The only difference is that this is happening in the ventricle and not in the atrium. Okay? Alright. So this is a rhythm strip of a patient who actually came to the emergency room and he was having palpitations and feeling very dizzy. When they connected him to the ECG machine, this is what they saw. Okay? So the hallmark of VTs, which all of you guys should remember, is that the QRS is very wide. See how wide it is? It is approximately 1, 2, 3, 4, 5, 6 small boxes. Okay? As compared to a normal sinus rhythm QRS, which is no more than 3 small boxes. Okay? So this is about 240 milliseconds. See how wide and regular it is? Okay? Whenever you see a rhythm like this, which is extremely wide, the QRS is extremely wide, you don't see any P waves. Okay? And the patient has a history of myocardial infarction or the patient is having chest pain, you should take this very seriously. Okay? Alright, so what do you guys think is the rate over here? What is the rate of this tachycardia? Well, let's just measure from one QRS to the next, and it looks about there about 2 boxes. So it's going to be 300 and 150. So roughly about 150 beats a minute. Okay? Alright. Do you guys think it is regular or irregular?
It is regular.
It is pretty regular. So it is ventricular tachycardia and not ventricular fibrillation. Okay? Do you guys see any P waves?
No.
No, no P waves. Okay. And when there are no P waves, there is no PR interval because you don't see any P waves. Okay. And we all discussed it. You know, the QRS is very wide. So the hallmark of ventricular tachycardia is that the QRS will be very wide. The patient most likely will be symptomatic and unstable, and it will be regular. Okay. All right. Now, what do you guys think is going on over here? Let me give you a history. This patient is actually, he was undergoing cardiac rehab, and he just had a big MI, maybe like 7 or 10 days ago. His doctor sent him to undergo cardiac rehabilitation, and all of a sudden he drops down on the floor. And when you guys connect him to the ECG cables, this is the rhythm you see. All right, so Fatima said it's ventricular fibrillation, and you know she's very correct, because in actuality you just see the baseline waving up and down, up and down, up and down, up and down, and see how irregular the QRS morphology is. This QRS is extremely wide. This QRS is even more wide, and this QRS is pointed. So there is no uniformity in the QRSs. They are very wide, they are irregular, and the patient is highly symptomatic. So this is an ECG of ventricular fibrillation. Now these rhythm strips that I'm showing you, this one and the previous two ones, they're actually from the ACRS exam, okay? And you will see these very often. We cannot really comment on the rate because the rhythm, because it is so fast. It is irregular. We don't see any P waves, and we cannot have a PR interval because there are no P waves. The QRS is extremely wide. The interpretation is ventricular fibrillation. Okay? This is a very dangerous rhythm to see on the rhythm strip. And the first thing to do when you see a rhythm like this is to shock the patient. All right. Now, you know, we went over this last time, but just to refresh you guys, arrhythmias can arise from various parts of the heart. You know, we just discussed how they can arise from the ventricle, and they can cause ventricular tachycardia and ventricular fibrillation. We just discussed how they can come from the atrium and cause atrial flutter. We just saw how they can arise from the AV node and cause SVTs. So whenever you guys see an EKG of an arrhythmia, try to generalize as to which part of the heart it's coming from. Okay? When you talk about arrhythmias that come from the sinus node, most of those are a normal physiological response to stress. Okay? For example, you know, when we run a marathon, for example, when we are stressed out and taking a test, those arrhythmias are most likely sinus tachycardias. You will see a P wave with every QRS, and the only thing you will find is that the rate will be more than 100 beats a minute. Now, in some people, especially the elderly and patients post-myocardial infarction, the sinus node can be diseased, okay? And in those cases, it can be too slow. And when it's too slow, they will have problems with dizziness, with syncope, and might sometimes require cardiac pacing, okay? All right. Yes. Okay. Now this is a tachycardia, the example of which we saw, remember, in which the QRS rate was 75 and all of a sudden it jumped up to 150. Most of those arrhythmias will be originating in the AV node or the AV junction. Okay? Now what you guys have to remember is that whenever you see a narrow complex tachycardia in which the QRS is narrow and you see no P waves, okay, always label it as a supraventricular tachycardia. It is an SVT unless proven otherwise. Most of these arrhythmias happen because there is a re-entrant circuit in the AV node, and just within the AV node there is re-entry causing extreme firing of impulses. Okay? Now the most reasonable thing to do in these arrhythmias, if the patient is stable, is to do a carotid massage. And if that doesn't help, the next step to do is give them IV adenosine. Okay? All right. Now, Let's go back to some more practice rhythms. This is the ECG of a patient who is 80 years old and has been having dizziness and has passed out a couple of times at home. Okay? What do you guys think is going on over here?
Patient got sinus bradycardia.
Good. So this looks like sinus bradycardia. And you can see the P waves are before every QRS, so this is sinus rhythm. And the rate is extremely slow, 300, 150, 100, 75, 60. So it's almost like between 25 and 30 beats a minute, okay? So this is an ECG of a patient who has symptoms, has sinus bradycardia, and will most likely require a pacemaker, okay? Very regular, very slow, P wave before every QRS, and the PR interval is normal. Okay, and see the QRS, it looks normal too. It's narrow and not wide. Sinus bradycardia. Okay. What do you guys think is going on over here?
Sinus tachycardia.
Good. So this is an ECG and a patient with sinus tachycardia. Okay. I once had a patient who was actually a medical student. And always before he used to go for a test, he used to drink a lot of caffeine, and often he would have palpitations, and it was all sinus tachycardia because of his nervousness and because of the caffeine in his system. All right? We see a P wave for every QRS, P wave, QRS, P wave, QRS, and the rate is about, I would say 130 to 140 beats a minute, okay? Close to that. Very regular, P wave before every QRS, and PR interval is normal. Okay, so this is an ECG of a patient having sinus tachycardia. All right. What do you guys think is going on over here? Alright, so you see a P wave before every QRS. This is a P, this is a QRS. This is a P, this is a QRS. P, QRS. Now what do you think happens here? What do you think this is? This is a PAC, correct? See how it comes in earlier than the other P waves. This is early. And the P wave morphology is you have a little bit of it positive, a little bit of it negative. Positive and negative. As compared to this P wave which is completely positive. So there's a change in P wave morphology. This P wave falls earlier than the other P waves. Okay? And the QRS stays the same. So this is a rhythm strip of a patient having PACs. This is the first PAC. This is the second PAC. Now sometimes PACs can be very symptomatic, okay? And if they are, we need to put patients on some medications. But in the majority of the cases, these are benign and no urgent intervention is required. Okay? Occasionally irregular, it comes in early. There's a P wave before every QRS. The P wave morphology is different, as we saw over here. This is a different P wave. This is a different P wave. And the PR interval is about the same. Normal sinus rhythm with premature atrial contractions. Okay. All right. What do you guys think is going on in this rhythm strip?
I would say that's another PSC there.
So this looks more like a PVC, right? It looks like a premature ventricular contraction. And the reason is, see how wide this QRS is? See how wide it is? Okay? And it's a completely different axis. This QRS is pointing upwards, and this QRS is pointing downwards, as compared to the PAC which you saw, in which the QRS has the same morphology as the sinus rhythm QRS. See? This QRS looks the same as this QRS, but in this EKG, this QRS looks very different from this QRS. It's wider, it's earlier, and you don't really see a P wave before it, as compared to the previous ECG in which we saw a P wave. This was a P wave and this was a QRS. But this ECG, there is no clear-cut P wave before the QRS, and it's wide. So this is most likely a PVC, or a premature ventricular contraction. Okay? Occasionally irregular because you don't feel it, it will come in only occasionally. Okay? You don't see any QRS coming in, a P wave, sorry, coming in before this QRS. Okay? And the PR interval in the other beats is just normal. It's normal sinus rhythm till all of a sudden there is a PVC. Okay, all right. Once again, just to refresh your guys' memory, this is a normal conduction system of the heart. Okay, the impulse originates in the sinus node. It goes down to the AV node. Okay. Then it travels down to the bundle of His, and then it goes to the left bundle branch and the right bundle branch. Okay. Now, all the arrhythmias that originate, they originate from this conduction system of the heart. They can originate from the ventricular myocardium, they can originate from the AV node or the sinus node. Now, Fatima just asked me, what is the significance of a PVC? Now, it all depends on whether a patient is symptomatic or not. As a general rule, all the PACs and PVCs, their significance is only there if the patient is symptomatic. Now, if a patient comes to you and says that, hey doc, I feel a skip beat every time I go to bed and I cannot sleep because of it, that patient's quality of life is being hampered, so we need to do something about those PVCs. But if a patient comes in routinely to the office and an EKG is done and you see PVCs and the patient is not even aware, then we need to leave those patients alone. The significance of PACs and PVCs is only there if the patient is symptomatic or the patient has developed congestive heart failure. If these two are not the deal, then we don't need to treat them.
Dr. Sewani, I have a question.
Yes.
In cardiac rehab, we commonly see PVCs in patients, but they normally come, in most patients they will come during peak exercise. You find that during warm-up you don't see them, at peak exercise you see them, then at cool-down they disappear again. Is there something that we should worry about?
No, this is a normal response of catecholaminergic surge. When you exercise, you have more hormones going in your body. There are more catecholamines. There is more norepinephrine in your body. And of course, the PVCs would appear at that time. And when you cool down, that surge, that adrenergic surge is gone, and the PVCs will disappear. You should not worry about the PVCs during exercise unless those PVCs are causing runs of ventricular tachycardia. Sometimes, patients will have VT or ventricular tachycardia which originates from a PVC. Okay? If that is happening during exercise, yes, we will worry about it. But let's say if every 6 or 7 beat is a PVC during peak exercise and the patient is asymptomatic, I would not worry about it. Okay?
Okay.
All right. Once again, showing the normal system, the impulse originates in the sinus node, goes down to the AV node, goes down to the bundle of His, and then it diversifies into the right bundle and the left bundle. Now, what happens when there is disease in these bundles? Let's say that a patient has had a myocardial infarction and the right bundle goes down or dies, which is often called the right bundle branch block, correct? And if the same thing happens to the left bundle, it is called a left bundle branch block. Now, these rhythm problems which originate in the bundle branches, in the AV node, in the sinus node, often cause pauses or widening of the QRS and the EKG. Okay? The first of these arrhythmias that we will discuss is going to be the AV nodal blocks. We went over this last time, but AV blocks are routinely seen in cardiac rehab. There are two reasons for it. The first reason could be that they have had a myocardial infarction that has damaged the conduction system of the heart. And the second is that they are on medications like metoprolol, atenolol, carvedilol, which will cause slowing of conduction in the heart. Okay? All right. We all went over first degree AV blocks, second degree AV blocks, and third degree AV block last time. And let's see if we can see some more examples of it. All right. So what do you guys think is going on in this ECG? We have a P wave and a QRS. P wave and a QRS. P wave and a QRS. But something is not normal. So what is not normal in this ECG?
The PR interval. The PR interval is too long.
Good. So the PR interval is extremely prolonged. A normal PR interval is no more than 1 box, which is 240 milliseconds. And the PR interval over here is close to almost 1.5 box. So this patient has a first degree AV block in which the PR is prolonged, but each P wave is followed by a QRS. So it is not like the patient is having any drop QRSs. All P waves are followed by a QRS. The only thing is that there is a prolonged AV interval or a first degree AV block. Now, in majority of the patients, this sort of a rhythm is completely benign. Okay? If you see a patient with a first degree AV block or a prolonged PR interval, once again, unless they are symptomatic, this is a benign condition. Remember that. Okay? Occasionally you will see that the first degree AV block is so prolonged that the patients are having congestive heart failure because of that. Unless that is the situation or the patients are symptomatic, I will leave this patient alone. Okay? Okay. So this is once again stuff that we just went over. This is what is important. The PR interval is extremely prolonged. It's about 360 milliseconds or 0.36 seconds. Okay? All right. First degree AV block. Okay. Now, what do you think is going on over here?
The patient has dropped 1 QRS.
Good. So this patient is having progressively increasing PR intervals, as Fatma pointed out clearly. This is the first PR interval, which appears to be normal. This is the second PR interval, in which lengthens. This is the third, which lengthens even more. And then this is the fourth one, and there is no QRS after this, right? So every fourth beat is non-conducted, and over here the third beat is non-conducted. Looks like the patient is having increasingly more and more durations of his PR intervals, and then you have a P wave without a QRS. Okay, so this is a typical ECG of a type 1 second degree AV block. PR prolongs and a drop QRS. PR prolongs and a drop QRS. Okay. Now this rhythm once again is not that dangerous. Okay. However, if a patient is symptomatic, if he is dizzy, if he is passing out, only under those circumstances you need to be worrying about this rhythm. Okay. If you see this rhythm in a patient who is totally asymptomatic, I would not worry about it. Okay. This is now when you check a pulse in such a patient, because every fourth or third P wave is not conducted, it is going to be irregular. Remember that. Okay. Not all pulses which are irregular are atrial fibrillation. Okay. Good. Second degree type 1. Once again, we're going to revise this. Okay. Now, what do you think is going on over here? This is a new rhythm strip. Okay, so let's analyze this ECG. Okay, now we start with a P wave and a QRS. P wave, no QRS. P wave, no QRS. P wave, QRS. So it looks like only 1 out of every 3 atrial complexes is conducted. See, this is conducted, these two are not conducted. This is conducted, these two are not conducted. This is conducted, these two are not conducted. This rhythm in which you see a PR interval that is pretty consistent. This is normal PR, this is normal PR, it does not lengthen. And every 1 out of 2 or 1 out of 3 impulses being conducted is a dangerous rhythm. This is consistent with type 2 second degree AV block because the PR never lengthens, the PR always stays the same. And a lot of P waves are not conducted. It is not like you have 2 conducted and a drop P wave. Only 33% or 1 in 3 P waves are conducted down to the ventricle. Okay, hence the rate is only 40 beats a minute. It will be a regular rhythm. You will see P waves all the time, but only 1 QRS for every 3 P waves. PR interval will remain the same, and the QRS duration is the same. Now, this sort of a rhythm is a dangerous rhythm. When you see a rhythm like this, in which the PR never prolongs, the PR stays the same, and only 1 out of every 2 or 3 P waves is being conducted, that requires us to take some action. And I would involve the cardiologist in this because this patient might end up with a pacemaker. Okay? All right. All right, now, what do you guys think is going on over here? Just a hint for this strip, try to analyze the relationship between P and QRS. If there is a relationship or if there is no relationship. The second thing, look at the width of the QRS as to how wide it is. Okay? Keep those 2 things in mind and I will wait for your answer. What do you think is going on over here? Good. So Fatima says it's complete heart block or complete AV block, and she's correct. This P and this QRS are close, but this P and this QRS are nowhere close. There is no association between P and QRSs. This is called AV dissociation. A for the atrium, V for the ventricle. This is complete heart block in which there is no relationship between the P's and QRSs. The P's are marching on their own and the QRSs are marching on their own. Okay? The rate of the QRSs is going to be extremely slow because this is a rhythm which is originating from the ventricle. Okay? This is not coming from the AV node, this is not coming from the sinus node. This is complete heart block with AV dissociation. Okay? Extremely slow rate, very regular, many P waves, but there is no relationship between P and QRSs. All these arrows are pointing towards P waves. There is no PR interval because there is no relationship between P and QRSs. And the QRS is extremely wide. Okay. This is 3rd degree AV block or complete heart block. Okay. Now, we went over the rhythm strips for patients in AV blocks or heart blocks. Now we are going to go over a little bit about supraventricular arrhythmias or SVTs. Okay? As the name implies, supraventricular means they are originating from above the ventricle, which means that they can be originating from the atrium or they can be originating from the AV node. Okay? There are some arrhythmias which we call SVT that originate from the atrium, which include atrial fibrillation that we are very commonly acquainted with, and atrial flutter, which we also saw an ECG of. The other arrhythmias that originate from the AV node are called paroxysmal supraventricular tachycardias because they start abruptly and they end abruptly. Most patients with atrial fibrillation and atrial flutter are older patients. Many patients with paroxysmal SVTs or arrhythmias arising from the AV nodes are younger patients. So you guys will be seeing a lot of AFib and flutter. I don't think you guys will see as much SVTs or as much paroxysmal SVTs because this is usually seen in younger healthy patients, but you can still see them. Okay. All right. So with this, we go on to our next rhythm strip. What do you guys think is the rhythm in this ECG strip?
I think it's sinus and it is irregular.
So you see, the first thing is that it is not regular at all. So this QRS and this QRS are far apart, and this QRS is so early. So this is an irregular rhythm, okay? This QRS is late, this is early, late, late, early, early, late, early, late. And you don't see any P waves. You see this junky baseline which goes up and down, up and down, up and down, up and down, but there are no P waves. Okay, there are no easily discernible P waves. So this is a typical rhythm of a patient in atrial fibrillation. It is an irregular rhythm with no P waves seen, and the QRS is normal duration. Okay. The rate of the QRS is about 100 beats a minute, but it's difficult to say. The rate is different here, it is different here, and it is different here. Okay. It is irregular. There are no P waves, and because there are no P waves, there is no PR interval. And the QRS duration is normal. Okay, atrial fibrillation. You will see a lot of atrial fibrillation. About 10% of patients more than 70 years of age have atrial fibrillation. And atrial fibrillation is becoming increasingly common as the population ages. Okay.
Dr. Siwane?
Yes.
How do you determine that the last up wave before the QRS is not a P?
Okay, so two things that you should see is that if there is, first of all, the P wave morphology. You see how weird this P wave looks, and then you see the baseline. Okay, this baseline is extremely wavy, and if you want to call these P waves, you will see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There are like 10 P waves before QRS. That is not normal, right? This is just a wavy baseline which is consistent with atrial fibrillation. There is no single P wave morphology between QRSs. This is nothing. This is just going down, this is going up, this is flat, this is up, this is down, this is flat. So you don't see any P waves at all. All that you see is a baseline that is wavy up and down, up and down, up and down. So this is not a true P wave. Okay, you have to see whether you can see a consistent morphology in P waves before every QRS. And the second thing you have to see is how regular the rhythm is. And the third thing I would say is look at the whole strip. If the whole strip shows like it's wavy up and down, up and down, up and down, that is most likely atrial fibrillation. See, there's no organized atrial depolarization, so no normal P waves. Okay, atrial activity is chaotic. This is the atrial activity. See how fast it is, and how irregular and how junky it is. Okay, all right. Now, this is a rhythm strip we just went over. What do you guys think this is? So this is a rhythm strip of a patient in atrial flutter. Now compare this with this. See how chaotic and irregular this baseline is, and see how uniform these P waves are. You literally see a recurrent pattern of P waves here. Up, down, up, down. But over here, you really don't make out any P waves at all. Here, you see very easily the P waves that are pointed up and down, up and down. Okay? So this is the ECG of a patient in atrial flutter. Okay? The ventricular rate is about 70 beats a minute. The rhythm is very regular. And you can see P waves which are going really fast, which are also called flutter waves. Okay? But they are there. You can make them out. It's not like you don't see any P waves at all. Okay? All right. Now, what do you guys think is going on over here? We went over this ECG also before. See how this is sinus over here, and all of a sudden it speeds up. Good. So Fatima says this is SVT, and as we had discussed, SVT starts suddenly, okay, abruptly, and it is very regular. It is very regular, as we see over here. The rate is right at 150 beats a minute. You don't see a clear P wave before the QRS, and it starts like this, abruptly. Okay? This is an ECG of a patient in supraventricular tachycardia or SVT. Sinus rhythm with a P wave, no P waves. Heart rate is slow, heart rate is fast, and very, very regular. Okay? Okay. Once again, you see P wave here in sinus rhythm, and you don't see a P wave here in the tachycardia. The tachycardia has a normal QRS, which looks just like sinus rhythm QRS. This is another clue. Okay? All right. Now, we're going to go over some examples of ventricular tachycardia and ventricular fibrillation now. Okay? Now remember one other thing. When we interpret ECGs or when we look at ECGs, a lot of it is pattern recognition also. You just cannot sit over there and fine-tune and analyze every detail in an EKG. It is the overall picture that matters. Okay? The most important thing for you guys in cardiac rehab will be to make sure that the patient is not having any ventricular tachycardia, the patient is not having any atrial fibrillation, the patient is not in any degree of heart block, he's not bradycardic. Okay? Remember, those are the most important things. The rhythm recognition in ACLS is the most important thing, and acute MI recognition is the most important thing. It really does not matter if you miss LVH or left ventricular hypertrophy. It really does not matter if you guys miss axis, whether it's superior axis, inferior axis, left axis deviation, right axis deviation. The most important thing for you guys to understand in cardiac rehab is arrhythmias, it is recognition of acute MIs, and it is even more important than that, it is to see if the patient is hemodynamically stable or not. Okay? All right. So we went over this ECG before too. What do you guys think is going on over here? It is a wide complex tachycardia. The QRS is extremely wide, and it is very regular. See? It is a recurrent pattern that is very, very regular, and the QRS is extremely wide. This is the width of the QRS. Good. So this is an ECG of a patient in VT, or ventricular tachycardia. When you see an ECG like this, you have to be very careful. You have to seek immediate help. You have to put the defibrillator patches on and get ready to shock the patient if he's hemodynamically unstable. Okay? Remember, this is the ECG of a patient in VT. You see no P waves before a QRS. It is wide and it is regular. Okay? Very regular, no P waves, no PR interval, and a wide QRS. Alright. Once again, this is another dangerous looking ECG, and this is the ECG of a patient in ventricular fibrillation, as compared to the previous ECG in which you could see regular QRS is going up and down, up and down, up and down. This ECG over here has a very wavy baseline. It is up, 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 down, up, down, up, down. There is no consistent QRS morphology. It is all over. It is extremely fast. Okay? Remember this pattern. This is a pattern consistent with ventricular fibrillation. Okay? There is no P wave. It is very irregular. The QRS is very wide, and the patient will most likely be unstable when you see this. Okay. Now, with this in mind, we will go on to the second part, which is important for you guys in cardiac rehab, and that is to diagnose if somebody is undergoing an acute myocardial infarction. Remember the three things I told you: ventricular arrhythmias, atrial arrhythmias, and diagnosing an MI. Okay? It is not very important for you guys in cardiac rehab to understand hypertrophy that much. It is not very important for you guys to even be worried about whether there is a left axis deviation or right axis deviation. By diagnosing an acute MI, diagnosing arrhythmias, these two are the most important parts. Okay? All right. First of all, as compared to just looking at the rhythm strip, which is usually 1 or 2 leads, to diagnose an acute MI, you need to look at the whole EKG. You cannot just look at one rhythm strip and say that, hey, this guy is having an acute MI. Okay, because the definition of an acute MI is to see ST changes in at least 2 consecutive leads. Okay, if you are ever worried about a patient who is having chest pain, has a history of coronary artery disease, and is having typical angina, the first thing to do is to get a regular 12-lead ECG on the patient to diagnose if he's having another acute myocardial infarction or not. Okay. If you look at just the rhythm strip, let's say this, you pick up lead 2. Okay, this bottom tracing is consistent with lead 2. You see nothing wrong here. This lead looks completely normal. There is no ST elevation, there is no ST depression, there is no arrhythmia. Without looking at leads V1, V2, and V3, no one can say that this patient is having an MI, because if you only look at one lead, it looks completely normal. So remember, to diagnose an MI, you need to look at a 12-lead ECG. Okay? All right. With this, we will go over some views of the heart. Okay, this is how the heart is placed in the human body. Okay, it is about the dimensions of our fist. If you make a fist in your hand, this is how big usually your heart is. Okay, now this is the anterior surface and this is the posterior surface. Okay, now when you're diagnosing an MI, it depends on where the lead is put. As we had discussed before, the precordial leads, which are leads V1 to V6, are oriented anterior to posterior. Okay, the limb leads, which are leads 1, 2, 3, AVF, AVL, and AVR, are oriented superior to inferior. Okay, so the limb leads will tell you whether a patient is having a lateral or an inferior MI. The precordial leads, which are leads V1 to V6, will tell you if the patient is having an anterior, anterolateral, or posterior MI. Okay. This is the anterior portion of the heart, and this is the inferior portion of the heart. The lead that is placed on the inferior portion will tell us about an inferior MI. The lead that is put on the anterior portion will tell us if there is an anterior MI. This is the lateral portion of the heart. The leads that are put on the lateral side of the heart, which are leads 1, AVL, V5, and V6, will tell us that the patient is having a lateral MI. Okay. Okay. The second criteria for diagnosing if somebody is having ST elevation or ST depression. Okay. The baseline that you compare with, okay, of course, the ST segment is the segment that starts from the J point, which is when the QRS ends and the ST segment starts. The segment between the T wave and the QRS is called the ST segment, and this ST segment will tell you whether or not there is the elevation or a depression. Okay. Now, always compare the ST segment to the preceding QT segment. Okay. Do not look at the PR segment over here and say that it is elevated or depressed. So for example, let's say that this ST segment is elevated all the way up here. But if you look at the PR segment, that is also elevated. Okay? So this will give you a false interpretation. Always look at the TP segment or the preceding QRS to diagnose ST elevation or ST depression. So one way to diagnose ST elevation is to look for elevation of the ST segment. This is the ST segment which is between the QRS and the T wave. Okay? Always look at this to diagnose ST elevation or ST depression. Now, as we can clearly see, there is ST elevation over here. There is ST elevation over here. And you compare it to the TP segment. Do not compare it to the PR segment. This is wrong. compare it to the preceding TP segment from the end of the T wave to the beginning of the P wave of the previous QRS to diagnose if there is elevation or depression. We can clearly see that there is elevation here, and elevation here. Now, how much of an elevation do you need to call it an ST elevation MI? Well, this is one big box which is comprised of 5 small boxes. You need to have an ST segment that is elevated by at least one small box, not the whole big box, one small box in at least 2 consecutive leads. So once again, how do you diagnose an ST elevation MI? You look at the ST segment. It has to be elevated by at least one small box as compared to the TP segment, and it has to be in 2 consecutive leads. So if this patient had ST elevation in only one lead, this is not an ST elevation MI. If this patient has an ST elevation in lead V1 and lead V5, this is not an ST elevation MI. They have to be present in 2 consecutive leads. Remember that. Clearly see ST elevations in V2 and V3. This guy has ST elevations in 4 consecutive leads, V2, V3, V4, and also in V5. Alright, so which leads tell us about which portions of the heart? These are the precordial leads. This is lead V1, V2, V3, V4, V5, and V6. The ventricle that we are concerned about the most is the left ventricle. Okay? Majority of the myocardial infarctions happen in the left ventricle. Very few, if at all, happen in the right ventricle. So if you look at this, view over here, when a patient is lying down on the bed or the table, his heart is pressed against the anterior part of the rib cage. Lead V1 is directly on top of the right ventricle, and lead V4 to V6 are directly on top of the left ventricle. V1 and V2 are on top of the right ventricle. This is the right ventricle. V4 to V6 are on top of the left ventricle. This is the left ventricle. Left ventricle, right ventricle. V1, V2 on right ventricle. V4 to V6 on left ventricle. Remember this. So, the anterior portion of the heart, which comprises of the septum and the right ventricle, are best seen in lead V1 to V4 because those are directly on top of the heart and they cover the anterior part of the heart. Leads V5 to V6 cover the lateral part of the heart. Hence, they will tell you if the patient is having a lateral MI. Okay. If you see changes in leads V1 to V4 that are consistent with a myocardial infarction, and what is that? It means that they are consistent with at least 1 millimeter of ST elevation in 2 consecutive leads. You can conclude that it is an anterior wall myocardial infarction because V1 to V4 lie on the anterior part of the heart. Okay? As you can see over here, there is elevation in V1, there is elevation in V2, and there is elevation in V3. So this is the anterior part of the heart. Okay? And as we discussed it before, this is an acute anterior infarction because there is ST elevation in V1, in V2, and V3. And these leads lie on top of the anterior part of the heart. Okay? Now, there are other MI locations. Okay? How do we know if the MI involves the inferior or the lateral wall of the heart? Well, we have to look at the leads that lie directly on top of the inferior or the lateral part of the heart. Which leads are those? The lateral part of the heart are signified by leads 1, AVL, V5, and V6. And the inferior part of the heart are signified by leads 2, 3, AVF. Remember, leads 2, 3, AVF will tell you if there is an inferior MI. Leads 1, AVL, V5, and V6 will tell you if there is a lateral MI. And leads V1 to V4 will tell you if there is an anterior or anteroseptal MI. This is just a revision once again. You know, lead 1 is in the lateral part of the heart. Leads 2 and 3 are on the inferior part of the heart. Lead AVR is on the right lateral part, and AVL is also on the left lateral part. Okay. Let's go over this again. V1, V2, V3, and V4 lie on top of the anterior and the anteroseptal part of the heart. ST elevations over there are consistent with an anterior MI. Okay. Which leads do you think tell us about the lateral part of the heart in this diagram? Leads V5 and V6, because they are based on the lateral side of the heart. Okay. Leads 1 and AVL are also put on the lateral side of the heart. This is lead 1, this is on the lateral side. This is lead AVL, this is on the lateral side. Leads 1, leads AVL, leads V5 and V6 are all positioned on the lateral part of the heart, and they will tell us that there is a lateral myocardial infarction. Okay. Now let's look at the leads that will tell us about the inferior part of the heart. See how this arrow is pointing down. 2, 3, and AVF are the leads that will tell us if there is an inferior myocardial infarction. Okay. So ST elevations in leads 2, 3, and AVF are consistent with the inferior MI. Alright. Question for you guys. This is the same ECG which we had looked at before. Where do you guys think is this patient having a myocardial infarction? Which lead is showing some ST elevation?
AVR as ST elevations?
Sure. So, you know, one lead that I had told you before, I had never mentioned lead AVR, okay? We seldom or if ever look at lead AVR, okay? So my recommendation to you guys when you guys interpret ECGs is to forget about lead AVR, okay? Just look at leads 1 AVL, 2, 3 AVF, and V1 to V6. Lead AVR has very little clinical significance, and for you guys, I would not even worry about it. So is there any other lead besides lead AVR that is having some ST elevation? Now this is a tricky one. You know, just look at lead 3. There is very slight ST elevation in lead 3. You see that? There is very slight ST elevation in lead AVF. And there's very slight ST elevation in lead 2. So these are the 3 leads that are showing slight ST elevations. But you guys are right. You know, it's not very clear. Okay. But once again, when we are dealing with cardiac patients, we have to look out for subtle things. So there's very mild ST elevation in lead 2, lead AVF, and lead 3. And hence, this is consistent with an inferior MI. Remember, leads 2, 3, and AVF show you the inferior part of the heart. Hence, it shows us about inferior MIs. All right. Now, what about this EKG? Where do you guys think there are ST elevations in this EKG? All right. So it's very diffuse. You know, lead V2 has ST elevation, lead V3 has ST elevation, lead V4 has ST elevation, lead V5 has ST elevation, and also lead 1. Look at lead 1, look at the ST segment, it's elevated here. Look at lead AVL, the ST segment is elevated here. So this patient is actually having an anterolateral myocardial infarction. The anterior leads, which are lead V1 to V4, are elevated. The lateral leads, V5, V6, 1, and AVL are elevated. So this patient is having a big MI, which involves the anterior, V1 to V4, and the lateral, V5, V6, 1, and AVL. Okay? So this guy's MI involves the anterior and the lateral wall both. Anterior leads are V1 to V4. Lateral leads are V5, V6, 1 in AVL. You guys have to remember this, okay? V5, V6, 1 in AVL are lateral leads, 2, 3 AVF are inferior leads, and V1 to V4 are anterior leads. Okay. Now, so far we have went over myocardial infarctions, we have went over heart blocks, we have went over VTs, we have went over AFibs and SVTs. What are you guys not comfortable with? I really want to know if there's a portion of today's lecture that you guys want me to repeat or go over more in detail. Because that's what all cardiac rehab and ACLS is about. You know, rhythm recognition, diagnosing acute MIs, diagnosing if someone is in heart block, and diagnosing if somebody is having a VT or a VF. The treatment of it is, of course, a separate part of ACLS, but my job to teach you guys is rhythm recognition and ECG recognition of MIs and arrhythmias. Which arrhythmia you guys are not clear with, and we can go over it again. And what I'm going to do is I'm going to give you guys a 5-minute break. Think about it and let me know. Okay, discuss this among yourself and I'll be back in 5 minutes. But please let me know before we proceed to the next section, because this is the core of cardiac rehab and ACLS. I'll be right back. All right, guys. Did you guys think about what you want to do, or you guys are okay with us proceeding?
I think the heart blocks are still a bit of
Okay.
and I'm having issues differentiating between fibrillations and flutters.
Okay. Okay. Yeah. So we can go over that again. Okay. And Fatima says we need to put in more practice strips. Okay. So do you guys gather ECG strips, like when you guys are in the field or when you guys are seeing patients? Do you guys have a collection of ECG strips that are confusing to you, or those strips you want to discuss?
Actually, the strips are available in the patient's files, so we could actually have a look at them in the patient files, yes.
Okay, you guys don't. Okay, that's fine. So let me just go back to heart blocks again. This is not perfect. Okay. So when we talk about heart blocks, we talk about three different types. We talk about a first degree heart block, we talk about a second degree, and we talk about a third degree. In the second degree, we have two types. We have type 1 and we have type 2. Now, the heart blocks that are dangerous and the heart blocks that should be concerning you are second degree type 2 and third degree, which is a complete heart block. The way to recognize these heart blocks is to try and first of all see if there is a relationship between the P waves and the QRSs that you see on a rhythm strip. That is the first thing I would do. The second thing to do is to see if every P is followed by a QRS. Remember these two things: relationship between P and QRS, and whether every P is followed by a QRS. All right, let's see. This EKG over here, okay, is an ECG of a patient in first degree heart block. As you can see over here, that there is a P wave and there is a QRS. However, the interval between the P and QRS is almost two big boxes. One big box, two big box. Beginning of P wave, beginning of QRS. The normal interval between a P and a QRS is no bigger than one big box. This over here has got almost two big boxes. So this is consistent with a first degree heart block. The only thing that you will see in a first degree heart block is that the PR interval, which is the beginning of the P wave to beginning of QRS, is prolonged. It will be more than one big box. That's all. There will be nothing else abnormal. Every P wave will have a QRS. Remember that. Every P wave will have a QRS. In other types of heart blocks, which are second and third degree, every P wave will not have a QRS. Okay? Once again, first degree heart block, the only abnormal thing is a prolonged PR interval. It will be regular because every P wave is followed by QRS. You will see one P wave for every QRS. The P wave morphology will be normal. It will not be changing like the ones that you saw in PSEs of premature atrial contractions. The PR interval will be prolonged. In a normal PR interval is about 240 milliseconds. This example over here is 360 milliseconds. The QRS will appear normal. It will not be wide. Just like over here, the QRS duration is normal. This is the ECG or rhythm strip of a patient in first degree AV block. This is most of the times a benign rhythm. All right. Now, this is the ECG of a patient in second degree type 1. We also call it Mobitz type 1 AV block. As you can clearly see over here, the PR interval, which is the beginning of the P wave to the beginning of QRS, is different for every beat. This PR is shorter, this PR is longer, and this PR is even longer until there is no QRS complex after this P wave. Once again, the PR keeps prolonging. Short, long, longer, dropped. Short, long, longer. The PR interval keeps prolonging. This is short PR. This is longer. This is even longer. And then there is a drop QRS. This is how a second degree type 1 heart block looks like. You would have PR prolongation and you would have drop QRSs for every third or fourth or fifth or sixth P wave. The relationship between P and QRSs, there is a QRS for every P wave for the first 3 beats, and then there is a drop QRS. So the PR lengthens until there is no QRS. This is the ECG of a patient with type 1 second degree. Okay? It is irregular because every 4th beat you will have no QRS. So when you palpate the pulse, it will be irregular. You will have P waves, but there will be no QRS after every 3rd or 4th or 5th. The PR interval will lengthen. Short, long, longer. QRS duration will be normal. Okay? Now, this ECG is an ECG of a patient with second degree type 2 AV block. You will have a QRS for a P wave, and then you will have no QRSs. There is a QRS, there is no QRS. There is no QRS. QRS, no QRS. QR, no QRS. So only 1 out of every 3 P waves. This is the first P wave. This is the second P wave. This is the third P wave. Only 1 P wave for every 3 have a QRS with it. Okay? There is no lengthening of the PR interval. The PR interval stays the same. This PR interval is the same as this PR interval, is the same as this PR interval. The PR interval stays the same. The only thing that you will see in the rhythm strip is that there will be blocked or dropped QRSs occurring regularly for every second or third or every 4th P wave. Once again, PR is normal, PR is normal, PR is normal. No QRS over here, no QRS over here. So it is not like the PR is lengthening. In the previous ECG, the PR was lengthening. See how it's lengthening? In this ECG, the PR is not lengthening. It stays the same, and there's no, and all of a sudden, the next P wave has no QRS. Okay? It is going to be regular as compared to the previous ECG in which the rate was irregular. Okay? PR interval stays the same, 0.14 milliseconds, 0.14 milliseconds. And the QRS will be normal looking. Alright. Now, this is the ECG of a patient in complete heart block. The first thing to see is how wide the QRS is as compared to this ECG. See how narrow the QRS is. This ECG has a wide QRS. This ECG is in a patient with complete heart block. There is no relationship between P and QRS. This P wave has no QRS. This P wave has a QRS that comes in so late. This P wave has no QRS. The PR interval is all over. This is short. This is long. There is none. So the escape rhythm is wide. There is no relationship between P waves and QRSs. And the QRS complex is usually wide. It's not narrow in complete heart block. Okay? So once again, remember this. No relationship between P and QRS. QRS is wide. Okay? And there is no fixed PR interval. This PR is bigger. This PR is shorter. Okay? This is a typical EKG of a patient in complete heart block. It will be regular because the escape rhythm is coming from the ventricles, hence it's wide. You will see P waves, as you can see them marching, but there will be no relationship to QRS. Okay? And the QRS will itself be wider. This is a wide QRS as compared to previous heart blocks. Okay? Now, the other thing that you needed me to repeat was the difference between atrial fibrillation and atrial flutter. Okay. This is the ECG of a patient in atrial fibrillation. Why do I say that? The hallmark of atrial fibrillation is that the rhythm is irregular. See how the distance between this QRS and this QRS is short, and the distance between this QRS and this QRS is longer. So it is completely irregular. There are no formed P waves. Okay? There is no definitive P wave morphology. This P wave is upgoing, this is downgoing, this is right at the QRS, this is before the QRS. So there are so many P waves that you can hardly distinguish if there is one single morphology. It is irregular. See how the baseline is going up and down, up and down, up and down. The atria are chaotic. They are beating so fast that the ventricular conduction is irregular. The baseline on this rhythm strip is wavy. There is no discernible P wave morphology, and it is highly irregular. No single P wave morphology, irregular, and extremely fast. This is how atrial fibrillation looks like. All right. Remember, the QRS morphology is normal. It is not wide. Okay. Can everybody see my presentation right now, or is there a difficulty? Nishi, can you see it? Hello? Can everybody see my presentation?
Nairobi, we can see you.
Okay, that's fine. I just wanted to make sure. All right. Okay. Once again, no organized atrial activity, so no normal P waves. As you can see, they're all chaotic and irregular. Atrial activity is extremely chaotic. Okay? All right. Now, this is the ECG of a flutter. See how well formed the P waves are? You can see a very well-formed P wave. It looks like it's a sawtooth. Have you ever seen the teeth on a saw? The saw that they use to cut trees and everything? It just looks like that. The P wave is very well-formed. It is very regular. P, 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 P. It is not chaotic like atrial fibrillation. You see how chaotic and irregular this is? This P wave is very regular and it has a definitive shape to it. Okay? So this is atrial flutter because the atrial rate is, if you measure, is almost one big box only. So this is 300. The distance between this spike and this spike is only one big box, which is 300 beats a minute. So the P waves are very well formed. They are regular and they have a shape to them. This is atrial flutter. The QRSs are mostly regular and you don't have a wavy baseline. You do not have a wavy baseline as compared to this, in which the baseline is all over. This is the difference between flutter and fibrillation. Okay? And we can easily measure the rates because they are so regular. The distance between this QRS and this QRS is the same. The distance between this QRS and this QRS is the same. It is very regular. You can see P waves, which are also called flutter waves because they are so fast. And there is no PR interval. Why? Because every fifth beat is conducted. See this. This is one flutter wave, this is second, this is third, this is fourth. I'm sorry. Every fourth flutter wave is conducted to the ventricle. There is no QRS following this flutter wave. There is no QRS following this flutter wave, but every fourth flutter wave is conducted. Hence, you cannot say what the PR interval is. But the QRS duration is normal. And this is how a flutter looks like. Okay? Now, this is the ECG of SVT, paroxysmal SVT. You have a P wave in sinus rhythm, and then all of a sudden, it becomes faster. Look at the difference between this P wave and no P wave here. This is not a P wave, this is just a flat segment. P wave, no P wave. P wave, no P wave. And all of a sudden, it just speeds up. The rate over here is about 75 beats a minute. The rate over here is about 150 beats a minute. This is a typical EKG of a patient who is in SVT. Okay? Once again, sinus rhythm with a PQRS, sinus rhythm with a PQRS, no P wave. All of a sudden, it just shoots up and becomes extremely fast. All right?
So
this
basically,
it looks.
So it basically starts as a normal sinus rhythm, then suddenly speeds up and it loses the
Yes.
P waves.
Now, it depends on when you get the EKG on a patient. The patient might already be in this rhythm when you get the EKG, so you will not see the starting of it, but you will see the middle of it. You don't have to see this sinus rhythm and then speeding up to this fast rhythm to diagnose it as SVT. You only can look at this part of the ECG and still say that it is SVT because there is no P wave here. You will not be seeing a sinus going into SVT. Most of the times you will be seeing the SVT only. You will not see this rhythm in most patients. You will just see this rhythm when they're already in the SVT. So you have to look at the ECG tracing. You have to see how fast it is, how regular it is, and if you can make a P wave before every QRS. If the answer is no, most likely it is supraventricular tachycardia. Now remember, it is about pattern recognition also. Okay? Once again, this is fast, regular, and there is no P wave before QRS. This is an ECG of a patient in supraventricular tachycardia. Okay?
Okay.
So the rate is about 150. It jumps from 75 to 150. Remember this pattern. Sometimes it is about pattern recognition. No P wave, extremely fast, normal looking QRS. Okay? All right. So this was just some basic EKGs about SVTs, AFib, heart blocks, and atrial flutter. Now what I want you guys to do is just pick up any simple ECG book, okay, and just go over some reading from that too. You know, just look at how a flutter looks like, look at how a SVT looks like, look at how an AFib looks like, look at VT. So look at those rhythm strips, look at those EKGs. It is a lot to do with rhythm and pattern recognition also, and not just trying to break down every beat of QRS complexes that you see on the strip. Okay, it is a lot to do with rhythm recognition. I think we will probably end our presentation here today, Nishi. You know, we have gone over a lot of stuff, and what we can do next time is just you guys can bring some examples of ECG, and I can bring some examples of ECG, and we can go over stuff trying to recognize patterns and trying to recognize the abnormalities that we see. Is everybody okay with that?
Yes, Dr. Swani, thank you very much. This has been a very difficult topic. I can say that maybe now we have maybe if we did an exam, you gave us an exam, we probably get 40%. We've got plenty of question marks, but question marks are good because they stimulate us to go and read more. So at the end of it, I think we are going to come out a lot better. Thank you.
Sure, sure. So I'm going to see you guys hopefully in a little bit, and I'll be in touch with Nishi. Okay?
Thank you very much, Dr.
Okay, great. Thank you so much, Dr. Sewani. Thank you, everyone, for joining, and then we'll see you again in a couple of weeks.
All right, guys.
Thank you.
Okay. Bye-bye.
Bye, Nishi.